may start.
Shabir, can I share my screen? Good afternoon, everybody. Welcome to this session. I hope you're able to see my screen and hear me. Luzanne, could you confirm that?
Yep.
Yes, we can, Champion.
Okay, thank you so much. Welcome to this session that's going to talk to primary healthcare in health professions education, an opportunity for interprofessional education. And I'm just going to give a brief overview of the build up to this particular session and talk specifically to the people that are going to be running this session and what are some of the expected outcomes. I'm Champion Nyoni, and I am currently at the University of the Free State in Bloemfontein, South Africa, where my primary role is a senior researcher within the School of Nursing. I currently chair the Africa Interprofessional Education Network, which I'm just going to talk briefly about in the next slide, and also a member of the AfroPHC or Africa Forum for Primary Healthcare, which I'll also talk briefly about since these are the two main organizations underpinning today's event. I also chair the Sub-Saharan FAMA Regional Institute Board of Directors, whose main function is around faculty development and professionalizing health professions education, and also work globally within the Association for Interprofessional Education. So as you can see, my primary interests lie around health professions education, competency-based education, which expects to a larger extent that professions needs to collaborate to meet the needs of the communities that they serve. So AfriPEN, or the Africa Interprofessional Education Network, is a consensus-based partnership organization that brings in education institution. I'm sorry, could you all mind muting your mics? Thank you. So as I was saying, that AfriPEN is a partnership-based organization that brings about education institutions, organizations, and even ministries of health with a primary purpose of advocating for the integration of interprofessional education as part of mainstream education in all our undergraduate health professions program. And we, as an organization, started in 2015 and have been growing since then. And at the current, in our current strategies, we're working towards creating networks within the African continent and also linking the African continent to certain partner organizations across the globe on looking at how do we capacitate our faculty, how do we work towards improving our policies, and how do we strengthen research, all of that in relation to interprofessional education. And in this particular organization, we operate in such a format that we do have an executive committee, which also is working closely with an executive board and specific working groups that focus on specific aspects of our mandate. And that has been sort of the model in which AfriPEN has been working on, and have had specific bilateral and collateral sort of relations with other organizations such as AfroPHC, the SAHI, which is the Southern Africa Association for Health Educationalists, and also AfriHealth. And all of this is trying to strengthen partnerships and also move the interprofessional education agenda forward. I also wanted to take this opportunity to mention that AfriPEN will be hosting its third Interprofessional Education Network conference, which is going to be an online conference in September from the 14th to the 17th of September. you can go and visit our website at afripen.org on more details about the conference, or you can also get in touch with me at the end of the session. As I spoke about, that we work closely and in partnership with various organizations. An important organization that we work with, which is actually driving today's agenda, is the AfroPHC. So what we're trying to do within the AfroPHC, or the African Forum for Primary Health, is to create advocacy policy and influence the direction in which primary health discourse, policy, research, and activities are done within the African continent. I know we are all aware of what the COVID has done and how much COVID has actually influenced the decisions regarding healthcare, and how we have seen the role of primary healthcare becoming quite pivotal within all healthcare systems. And through AfroPHC, we're trying to bring such a debated discourse within our forefront. AfroPHC has a board which was newly established, and we work through the capable and coordinating hands of our executive secretariat, which is based at the University of Witwatersrand, Professor Shabir Musa. And through that secretariat, we've been able to constantly have these type of conversations within the continent around particular areas, from the clinical issues in PHC to research issues in PHC. And today we're going to be talking about interprofessional education. I would advise you to also visit the website afrophc.org to get an updated list on some of the activities that AfroPHC is about, and also register for membership to get your own personalized communication regarding AfroPHC activities. So it is quite clear that there is a very direct link between what we consider as health professions education and primary healthcare. As we know where we're coming from within the African landscape in terms of designing and influencing curricula, that majority of our programs have been hospital-based programs that focus on training students to deal with specialized type of diseases and illnesses. But with the advent of the primary healthcare model, and also a bit of revitalization within our education mandate, it is becoming clear that the way in which health professions education should be looked at within all the curricula, both should it be nursing, should it be medicine, etc., they all should have a primary healthcare approach, and primary healthcare should embed the description, the design of health professions education, especially within the African context, where we know that a majority of our population actually receive their healthcare within the primary healthcare system. And for that particular system to work effectively, we are all aware and clear of the role of possibly what interprofessional education and collaborative practice could actually do. In addition to this sort of conversation, the main purpose of today's activity, discussion, conversation, and workshop is all around how can we link health professions education for all the disciplines, all the professions, primary health care, and what is the opportunity for interprofessional education. And I wanted to take this opportunity to thank the team from the University of the Western Cape, who is really doing amazing in terms of leading the discourse in interprofessional education, particularly within the continent. I think they recently also launched a postgraduate diploma in interprofessional education. I'm sure somebody is going to talk about it, which is a first of its kind within the African continent. And it is really a commendable effort done through this university. I'm just going to take this opportunity to briefly introduce some of the speakers that are going to lead this debate, this discussion. And I'll start this by introducing Cassandra Carrols. Cassandra Carrols is was raised and currently is residing at the Cape Flats. Those are the qualifications I think you can see from the screen, also from the University of Western Cape. She's currently pursuing a PhD in psychology, which focuses on young adults and risky behavior. She's currently employed in the Interprofessional Education Unit and works within the Mitchell's Plain as a field worker coordinator and the manager for the UWC Vaccination Center. Our next speaker, or part of the panel of speakers today, is Takwing Yu. I hope I pronounced your name well. Takwing is an associate lecturer in the Physiotherapy Department. His research interests include learning and teaching using technology, clinical education, and virtual reality. And he's currently registered for his PhD in the field of virtual reality in physiotherapy. The next speaker is Dr. Serena Isaacs. Dr. Serena Isaacs is a senior lecturer and a registered psychologist in the Department of Psychology, again at the University of Western Cape. Her research interests lie in community psychology, child and family community resilience studies, and she facilitates both undergraduate and postgraduate level, including PhD students. The next on my list is Violet Adonis. Violet is a registered social worker who graduated from UWC and also from Norway. And over the last few years, she has worked in teaching and learning in various settings, including universities, TVET colleges, and also schools. And she briefly worked in domestic violence sector, and she has the ability to work with the elderly, women and men, and she has passion to work with young people. She's an accredited assessor, and she wishes to combine her social work knowledge and experience in the delivery of best services to whom she works with. The next person who's also going to be facilitating today's discussion is Labeeqah. I hope I pronounced this well. She is an associate lecturer at the Interprofessional Education Unit, again at the University of Western Cape, and she coordinates various modules within that unit, which includes service learning, which has moved now online due to the COVID-19 pandemic. Labeeqah's role is rooted in the provision of interprofessional education and training so as to ensure the emergence of skilled, team functioning health professionals. She has published in this area and has facilitated numerous workshops and capacity development training sessions in the field of IPE. So this is a part of the great team that we're going to be having that's going to be facilitating the session today. And I wanted to hand over to one person who has been leading the coordination of this particular workshop between UWC, AfroPen, and AfroPHC. And I wanted to give her this opportunity to actually introduce herself and also take over in running this show. Luzanne?
Can I ask quickly that attendees just fill the poll in so that the team can actually have a sense of who's in the room. If you don't mind, Luzanne, giving them a few seconds.
No problem, Prof.
I think if we can get at least half of the people, it will be great. Well, you've got a wide spread of people apart from South Africa. All right, let me just, people are too busy. Okay, I'll stop it here and then we can share the results. There you can see it. It's a fair number of people from all across Africa. with professions from doctor, nurse, clinical associate, community health worker, and other. But we don't get the other, but it'd be great to do that the next time. Thank you.
Thank you so much. Thank you, Prof. Thank you so much for that introduction, Champion, Dr. Champion. I'm going to ask if you can stop sharing, then I can just share my screen as well, please.
Okay, just a second.
Thank you. Okay, so before I share my screen and while Champion's taking his presentation down, I'm Luzanne Cook Africa and I work for the Interprofessional Education Unit. We are very excited to have this opportunity to engage with you all on such an important topic. I think primary healthcare is such an integral part of our health systems, and because of the low resources that we have in our countries, it is often overlooked, and the majority of things like funding gets allocated to our tertiary hospitals. And so this is an important discussion to start having and to start engaging at the health professions education level, and so we can take it forward as we move along. I'm just going to share my screen quickly. Okay, there we go. So, can I close this? There we go. So welcome everyone. As Dr. Champion mentioned, today's session will be about primary healthcare in health professions education and how this can be used as an opportunity for interprofessional education. I think for so many years, the discussions have been there about the importance of IPE and how we must move it forward. But I think that once the discussion starts of where overlap is in departments and where certain departments are still lacking in relation to certain principles of primary healthcare, I think that's where the collaboration can start happening. And so just for us to all be on the same page, I think we need to have this common understanding of what primary healthcare is. Is my slide not moving? There we go, sorry. So on the screen, you'll see quite a lengthy description of what primary healthcare is. And I think even when we teach this to our first year students in our primary healthcare module, we find it important to break it down into the different components or aspects of this definition. And so there are 5 aspects that this definition can be broken up into. And the first is that primary healthcare plays an important role in the improvement of the health situation. And then secondly, it is feasible because it's not too highly pitched. And thirdly, the methods are specific, which means that it is not second-rate healthcare and that it's acceptable to whom it is meant, so population specific, basically. Fourthly, the technology is accessible, meaning that machinery and such resources are available to the entire population. And then lastly, it is affordable, which means that it is relatively cheap. And so if we look at primary healthcare and we look at that definition and the different aspects of the definition, we see how this ties into what we know as the principles of primary healthcare. I think I'm too impatient with this technology thing. But there are 5 principles of primary healthcare, and each one of these will be unpacked by our speakers as we move along. But the first one, if we look at the first principle, that is equitable distribution. And when we speak about equitable distribution, it can be defined as the distribution of health professionals in communities to ensure accessibility to appropriate healthcare by appropriate health professionals in an appropriate time frame. And so at UWC, a vaccination center was launched to ensure that the distribution of the COVID-19 vaccine service was available to the entire UWC community. And so the operations manager of this vaccination center is Cassandra. And not only was this Ph.D. candidate born and bred on the Cape Flats, she is currently the fieldwork coordinator for the IPU in the Mitchells Plain community. And so this personal and professional experiences has led Cassandra to develop a strong understanding of the importance of ensuring patient access to appropriate quality healthcare. And so I hand over to Cassandra. Cassandra, would you like me to share your presentation, or will you be doing it?
You can share the presentation.
Okay, I'll do that.
Thank you.
Okay, you can just tell me when I must move the slides and all of those things.
Okay.
Cassandra, do you want to show your videos?
I'm not sure what's happening with the technology here.
All right. Okay.
So I'm not sure, it's not wanting to show the video. It's not wanting me to show the video. I have got my video on, but it's not.
Don't worry.
Showing.
Don't worry.
Okay, so I'm Cassandra, as Lizorn explained, and I will be talking about equitable distribution. Lou, you can move to the next slide. So as mentioned, equitable distribution is one of the is the first principle in the 5 principles of primary health care. And as Lizanne explained it, it has been defined as the distribution of health professionals in communities to ensure accessibility to appropriate health care by appropriate health professionals in an appropriate time frame. You can move to the next slide. This ensures that individuals with more compromised health conditions will receive more healthcare services. Commitment to healthcare equity focus not only on ensuring program inputs, but also reducing the differences in health outcomes. The inequity in availability of healthcare services still remains a major concern in our country. The supply of healthcare resources or in the past has been seen more towards the affluent or areas in which they can afford healthcare services. So generally focusing on those areas that have access to medical aid, and those that does not have this access generally struggles. The access to healthcare has thus been explained in horizontal equity as well as vertical equity. By horizontal equity, it basically focuses on equal access for equal needs. So it will focus on equal resources, equal access to healthcare, equal utilization of healthcare services, as well as equal health. However, in a diverse country such as ourselves, we also need to consider the vertical equity, which is unequal. Unequal should be treated in proportion to the inequality. This basically means, Lou, you can move to the next slide. This basically means that the individuals that require more need should receive more treatment. Lou, you can move to the next slide. So, so individuals that are needing more health, more need, will then receive more treatment. The central theme of the need, therefore, determines the equity. And aspects of this equity in health and healthcare is seen as equity in access to healthcare, equity in health, as well as effective coverage. You can move to the next slide. So with the pandemic such as COVID, there's a rising need for equitable distribution, especially with healthcare. As we have seen during 2019 with the influenza H1N1 pandemic, the wealthier nations bought virtually all vaccine supplies, and thus there was an unequal distribution to more poorer countries. The development and the widespread distribution of COVID-19 medical treatments are a common global interest, and thus we have been seeing, and it's been going on for more than a year now, and the ongoing need with the different variants that are surfacing, it's becoming more and more an interest to the global spectrum. COVID-19 has caused a scarcity of medical resources in healthcare systems, and in South Africa, our healthcare system has been severely affected, as well as the global economy. So it's not just South Africa that's suffering; it's everywhere that this has become an issue. In South Africa, our healthcare services are suffering under immense pressure to delivering services both in our poorer communities as well as in the more affluent communities, both public and private sector. Achieving the global equitable access to COVID-19 vaccines and therapeutics has been seen as very difficult. Therefore, there was an opportunity for equitable distribution. To overcome the inequality, you can move to the next slide. To overcome the inequality, the concern of attaining health equity is no longer the domain of healthcare professionals only. A multidisciplinary action involving diverse resources is desperately needed in order to achieving the goals that we need to, in order to ensure that the primary healthcare system runs function adequately. You can move to the next slide. Therefore, the framework for the distribution, as what we have also applied at UWC, is it needs to be flexible and have trusted governance, adequate resources, open collaboration, and evidence-based healthcare-driven allocations. Therefore, at the vaccination site at UWC, the goal, Lou, you can move to the next slide. The goal was to provide effective, efficient, and overall amazing experience to all patients receiving the vaccination, and also to alleviate the burden from the public healthcare system. So the population that UWC has targeted was all UWC staff, students, and family members that are eligible to be vaccinated. And this is in collaboration with the Department of Health. All receiving the same fair treatment, despite what, whether you're from public sector or private sector, if you are affiliated to the UWC population, you are eligible to receiving the vaccination. And this is in accordance with the general rollout as per the Department of Health. So in the first phase and 1B was the healthcare workers, which was under the Sisonke trial, and we then continued with the 1B as well as servicing the 60 plus population. So that was all staff that was eligible in that age group, as well as the parents, as well as spouses that fit into the age group. And we have now successfully moved through all the age groups, and we are patiently waiting for the 18 plus population to open up. Can move to the next slide. And so how does this look in terms of the collaboration to overcome the COVID-19 pandemic with the vaccinations? And this is in collaboration with the Department of Health and UWC. So on the one hand, you have the Department of Health, which is the public sector, and then you have UWC. You can move to the next slide. And with UWC, we have a wide range. And earlier I referred to that we cannot just look at health professionals, but we also need to look at other disciplines to and draw on other resources in order to achieving that all patients receive the same kind of treatment. So UWC, together with that is run by the COVID-19 vaccination site team, is a multidisciplinary team. So it's different disciplines that have come together and is working to planning and managing the vaccination site. Waste management, we have the vaccinators, student administrator, assistants, communications, volunteers, risk and compliance, and CPS all work together to ensuring that the product or our goal is reached, that everyone is has an effective the goal is my goal to provide effective, efficient, and overall amazing experience. So everybody works together in order to achieve that goal. You can move to the next slide. How do we work together? We have the shared planning and management, and that is done by the vaccination site team. This team consists of various bodies across campus, various departments that all work together to ensure that the vaccination site is able to run. This site then has a coordinator that corresponds directly to the Department of Health. And so everything that is done and is expected from the Department of Health is then run through this vaccination site team. They are then responsible for the planning and the management of what happens in the vaccination site. We then have the implementation. This involves a site coordinator as well as the operations manager, and that's where I fit in. And once the planning has been done, the implementation on the day-to-day running of the site then happens with the site coordinator and operations manager. And simultaneously, communications then get sent out to all the bodies in UWC. So this is done via email, it's done through WhatsApp groups of various departments, as well as word of mouth throughout the community, so that all UWC staff, students, and their family members are aware of what is happening, and to make sure that is accessible to them. We then have a range of different parties that play a role, which is our booking team. They book the patients and manage inquiries and different queries that may come. Operations manager then, together with the Department of Health, ensures that there are enough vaccines for a specific day. The vaccines are collected from the Department of Health on a day-to-day basis, and this is done by a private security company to ensure the safety of the vaccines. We then have our vaccinators that prepare our vaccines, and then we also have our student administrators, which does from check-in right through to logging the vaccinations on the departmental site. And then at the end of the day, we then report back to the Department of Health. This then is then reported back to the vaccination site team, which then revises the week. And then at their weekly meeting, they would see if there needs to be changes or not. You can move to the next slide. Our results thus far, our total to date, from the 8th of June, we have vaccinated 2,801 patients and counting, and this is for first doses as well as for second doses. The total number of days that we've been operating is 39 days, and you can see that there's been, this graph just depicts how each week has been accessing or the implementation of the vaccination site. And then if you look at the last slide, we can go to the last slide. And this is just the product of our goal, which is to provide effective, efficient, and overall amazing experience to all our patients in receiving the vaccination. And here is just some of the feedback that we've received from various people that have come through our vaccination site, that was speaking about how efficient the service has been, and as well as because receiving the vaccine is such a anxiety-provoking experience, that they have gone through the whole process without much anxiety, and they were very pleased. And I think in that, with all of the different bodies working together, we then have concluded that we are running our site successfully but this couldn't have been done if all the different departments was not playing the specific role, from the team to even our waste management that collects our medical waste, to the security, to our student administrators. So this is how UWC has effectively applied the equitable distribution and ensuring that all our staff members, family, and students receive their vaccines. Thank you.
Thank you so much for that, Cassandra. I think Cassandra's topic, just for us to have an understanding of what is happening at the vaccination site, is so important. The rest of the speakers for today will be speaking about specifically health professions education, but I think it was just important for us to share what is currently happening at UWC that ensures equitable distribution for our population and for our community, for our UWC community. And so let me just share my screen, sorry. It's so appropriate that the next talk will be on this topic because it's not something I'm very good at. Oh no, sorry. Here we go. It's going well. Sorry. So the next principle that we have is is appropriate technology. And appropriate technology has been defined as the importance of developing innovative models of healthcare and the dissemination of health research findings. And so if we look at this in a health professions way, it doesn't always speak to primary healthcare. It does speak about how do we ensure that there's appropriate technology for our students as they move along. So in the primary healthcare module at the first year level, we do incorporate different forms of technology, but how do students move along from their first year level and then go and explore different types of technology in order for them to then explore this when they are qualified health professionals? And so from his undergraduate degree in physiotherapy, Takwing has always been seen as the technology guru. From his fancy gadgets, unfamiliar to me, I would say to most, but to me, and the strangest apps, Takwing can be seen testing all of it. He said something about smart glasses today. I'm not sure if that was him trying to be funny or if it's actual smart glasses, because I don't know. As you could see, I couldn't even share my screen properly. But Takwing's love and passion for technology is not only evident in his teaching practices, but also through his Ph.D. that he's currently working very hard to obtain. But it is focused on technology and physiotherapy teaching and learning. So I hand over to Takwing. Thank you very much, Takwing. You can go ahead. Takwing.
Hi everyone.
There we go.
Sorry. Thanks for the great introduction. My name is Takwing. I'm from the Physiotherapy Department, associate lecturer there. I'm currently doing my master's. So what I want to talk about today is one of the principles of appropriate technology in primary healthcare. Okay, so when we look at technology, we often ask the question of, what is technology? Do we actually understand what this technology is? So technology is the application of scientific knowledge for the practical purpose, especially in industrial use. I would like to define technology not as only a digital tool, but actually a tool in general. So I like making the comparison of, a caveman without a club, and compare that to a caveman with a club. So the biggest difference between the two is that he has a tool that can assist him to make the process or to reach a specific goal a lot easier. And that's what I see technology as. And whether this tool is applicable or whether it's appropriate or not, that's really up to the local needs and whether this is accepted by the user themselves. So there's no point for us to get a very high-class technology into the country, for example, a highly ultrasound diagnostic machine, and no one knows how to use it, and it's not applicable to the population. So therefore, this is where the principle will come in with appropriate technology. Okay. The reason why we use technology in primary healthcare is we always need to find new ways or new innovative models for primary healthcare. So this looks at the importance of improving availability and accessibility, allowing our patients to easily access information or content. Then it also allows the reflection of, can we decrease the cost of certain equipment, and how do we improve the scientific validity and the acceptance of these equipments and techniques used by health professionals. And lastly, reliability and validity. How do we ensure that all the tools that we use is reliable and is valid? So therefore, technology plays a big role there. And I'd like to strike some examples like medicine, for example. So we always have, for example, allergics, right? We use allergics, and technology has improved allergics in such a way that there's no more, or they decrease the signs, the side effects. And vaccines, we know Johnson & Johnson and Pfizer very well. Without new technology, we won't be able to produce vaccines and new or better diagnostics. Then technology can also help with rehabilitation, creating artificial limbs or curative care and AIDS rehabilitation. So, and another technology that I would like to talk about is something that we all have access to, for example, smartwatches or ECG on the watch or heart rate sensors on the watch. Also, the applications that are available on the mobile devices that patients can virtually access doctors and ask questions to find out their diagnosis. So that can also assist patients in gathering information. So what I want to talk about today is I want to take this appropriate technology and shift it to a curriculum approach. So how do we use appropriate technology in the curriculum and how do we apply it? So as we know, the new generations of students, they learn differently. They have a more of a flexible approach. They more have a personalized approach to learning and achieving their goals. And this new generation is technology native. So technology is not second to them. Then I would like to bring the 4 platforms that I use quite often, which is Google, Zoom. This is the platform that we're using at the moment. Equitable, which is a content sharing platform, and a website called WordPress. So Google Suites contain Google Meet, Google Drive, Google Rooms, which is a new function, Google Forms, YouTube. Then online, we look at, for Zoom, is an online platform where we can present, where we can do workshops, etc. And Equitable is where I kind of dump all my content and material on, where students can then go and access it. WordPress, similar to Coursera, which is like an online course. So I'll just explain a little bit about how I use each of the platforms to achieve my teaching goals. And for me, each of these platforms has its unique property. Of course, you can challenge and say there's other platforms that are better. Of course, there always is, but these are the ones that I chose to do my teaching on. Then, so the first thing I want to talk about is Google Rooms. Now, Google Rooms creates a platform where you can share content, but not just sharing of content where I download the content and I read the content, but a little bit more in depth is I would like the students to engage and to collaborate within that context. And Google Room does exactly that. So you can create a room of a certain amount of members using their emails, and you can create chats. So you can create threads very similar to maybe your Instagram or your Twitter approach, and students can reply and comment based on how or what you've placed there. And you can create mini discussions, or you can have a full-on discussion with students. You can share files with them through Google Drive, and everything is collated in that area, in that folder. So students can access it at any time. You don't have to worry about the document being lost, etc. And what I really enjoy about Room is that you can assign tasks. Now, we always have that problem of, we tell the students, you guys lack in this area, please go back and read about this. Assigning tasks to a student is almost giving the student a to-do list, where you link them to a specific article and say, Peter, can you please read this article and explain to the class or explain to the group thereafter how this article is appropriate for the treatment technique that we're using, which makes it very direct to the student, and it's not general, so students don't feel like someone else will do it. It's assigned specific to them or to that group. Then we know Google Docs. I use Google Docs quite often. I'm sure researchers also, how to, it's nothing new. It's live editing, you can comment, you can interact, etc. It's a very useful tool that I use for case studies, especially now when we can't go to the clinical platform. So students engage, I give them a case study, and they engage in the case study by leaving comments. So they would write something like, I'm not sure if this makes sense. can you explain this better? So on the Google form, on the Google Docs, we can have mini discussions on the side. And addition to this, we can bring this into the Google Room and have a bigger discussion there. And in addition to this, I feel maybe the Google Docs commenting on text is not enough. And so it was proven that we leave voice notes now. Texting on WhatsApp sometimes is a bit of a pain. So we leave voice notes and we can listen to them over and over again to get the message. So they incorporate this idea in Google Docs where you can highlight a certain text very similar to what you do in terms of your Google Docs comment, and you record a message and you insert it. So what the student does is they look at the Google Docs and they listen to your voice talking over this comment. And studies have shown that students retain the voice notes better and they apply it to their work better compared to the text comment. And also the person giving the comment can apply this comment a lot easier, can give this comment a lot easier. I think sometimes we lack the tone. So when I'm talking to someone over voice, it sounds, my tone is better. And they can understand that I'm not asking a sarcastic question, is that I'm actually asking a critical question that they need to think about. And I also feel like leaving a voice note in a comment brings the student and the lecturer together closer than having this, I'm the lecturer, here's the student. And sometimes the students also don't reply to the comment, where in a voice note, you can give more concise information in a shorter period and the students don't have to read a long text. Then another common tool that I use is Google Forms, which is presented by Google. I'm sure most of you have used it, if not, have received a link to get used by it. So Google Form also offers something, multiple choice questions. So you can create a automatic marking system through Google Forms, which is MCQ. You populate the question, you populate the answer, Google marks the question for you. Now, of course, there's many platforms out there that can do the same. However, what I enjoy about Google Forms is that it creates a graph based on the replies that you get from your participants. And what this can be used for is, in class, you can send this link out to the students, and you can tell the students, we just covered a very important concept or a very important section, and I need to make sure that you understand the concept. You send this question out, give them 10 minutes, they answer, and they present, and at the end, when everyone's submitted, you go onto Google Forms and you get pie charts like this, which you don't need to look who submitted what. You can just look at generally how the class has done. So this was a very good example. So question 1, most of the students understood that the answer was true, and only a few submitted false. However, in the second question, we got a nice split in between. So there was half the class said, a little bit more than half the class said true, and less than half the class said false. And what this does is now you can bring this up on your projector or on your share screen and say, look, half the class didn't understand this concept. What can we do to engage here to make the other half understand? So you can have two options here. You can ask those that said true or those that said false to defend themselves and create this engagement environment where students can say, well, I thought because of this, this, and that, and then the lecturers can step in and facilitate the process, which allows the engagement in this online platform. And what you can also then use this for is something called a 10-mark test. Now, in McDaniel's study, he said that classes that go through a small amount of assessment or quizzes throughout the year have a better recall and better retention of knowledge. And this is more so with subject that requires a large amount of recalling, such as anatomy and physiology. So if your module or your subject requires that, Google Form could assist you, and these 10-mark tests are pretty easy to set up, and the students can redo the questions until they grasp the concept or until they understand the concept. And of course, you can ask, why Google? Why not Zoom? You guys answered the poll earlier, I see. So similarly, polls does the same thing. So it just really depends on which platform you prefer. Now, for me, I prefer Zoom because I can create breakout rooms where if there's 60 people and we want to have a case study discussion and we divide them into groups of 4, we create a breakout room of 16, for example, and I can jump between those breakout rooms and collaborate with the students and listen to their discussions and see how they are progressing with the activity. Addition to this is Zoom also allows local recording, where Google Meet is a online storage, which doesn't really matter. You can of course download it and upload it to whichever platform you want to use. However, when I do a local storage, it creates two types of files that I find very useful. The one is the actual recording, which has your video, your footage, your presentation, etc., and everyone's cameras. And the other one is a pure audio. And then what I like to do with that is I upload it to a podcasting platform, and students can listen to that, my lecture, as a podcast. And when they want to, they can go back into the lecture, go look at the PowerPoint, and they can go through the content. This obviously promotes synchronous and asynchronous time of teaching, so then students can listen to it in their own time. Equitable is our kind of learning system that we put all our content on, and as you can see, we share our lectures, our audio, our video, the chat that happens in Zoom, and the PPT, so the students can go and download this at their own time, and it is zero rated, so students can download without any data costs. But I also upload this into Google Drive, so whichever way that students wants to access the information, it is really up to them. Then the last platform that I use is something called WordPress. And I use this in the module that is called management. And management talks a lot about policies, acts, and labor laws. It is not a talk about management of a practice. And sometimes some of the content is not really class engaging. So it's a lot of listing and a lot of policies. So what I did here was I upload all the course content, the PowerPoint, the pre-recorded lectures into this website, and I embedded all of them in. As you can see here, I used YouTube with lecture 1.1 and lecture 5, and students can listen to it, go through the course by themselves. And what this does is, of course, it doesn't replace my lecture. It just frees up my lecture time. And now I don't have to go through the list. I don't have to stand in front of the students and read through the PowerPoint, where the student can go through the PowerPoint, understand the concept. And in my class time, now I have discussion on lecture 1, 2, and 3, where the class can be a lot more engaging and more active in the classroom activities. And the big question, are these technology appropriate? Do we use Equitable? Do we use Google Docs? Do we use Zoom, Meet, eBooks? Which one's more appropriate? I think it's important for you to decide how you want to set out your learning outcome. So out of all these platforms, they're all appropriate, but you can of course do a survey and say which the students prefer, but each of the platform has its own property, and the outcome is set by you, or the lecturers in this case. And I thought these four platforms were appropriate based on the 6 learning types. Right, so we have acquisition, discussion, collaboration, investigation, practice, and production. So acquisition talks about the student going through the lectures, but they don't do anything, they just listen, observe. Where investigation talks about the student going to the teacher or going to the library to actually have to find out information. And that we can achieve by doing using Google Docs or Google Rooms. Discussions, we can have breakout rooms. This is about exchanging ideas, challenging, arguing, and practice, I spoke about Google Forms, where students can constantly redo certain tasks until they understand the concepts. And collaboration is about working together on the project. So that can be done in Google Docs or Google Rooms by sharing documents, especially in case studies. And then production, which could be assignments or presentations where students have to produce a kind of a tangible outcome for evaluation. And I feel the 4 platforms cover the six learning types quite adequately. So that's why I chose those 4 platforms, leading to these 6 goals. Yeah, so thank you for listening. This is the end of my presentation. So there are many platforms and technologies that we can use to enhance learning. However, if technology is kind of is inhibiting you from using it, from producing a better teaching method, then maybe it's not the right type of technology that is applicable to you. So like I said, there's many platforms that you can use, explore them and see which one is more appropriate for your use and for students learning. Thanks for listening.
Thank you so much, Takwing. I really enjoyed that. I had a bit of a dry run with Takwing earlier this week, and how did I still manage to learn more? I'm always learning something new from Takwing, even if it's through him shouting at me because I don't have the latest technology. But thank you for that, Takwing. We are going to move into a quick activity. I'm actually just going to share my screen for you to. It's me with sharing screens again. Okay, so the first activity we will be doing involves Mentimeter. I'm not sure if you are aware of the platform, but you can log in by going to www.menti.com, and they'll ask you to enter a code. I'm actually going to put the code in the chat as well. I think it's just easier to copy and paste from there. So you can just enter that code into Mentimeter, and then I'm going to ask my colleague Claudia, Claudia Swinney, do you mind unmuting yourself and just putting on your camera and then running through the responses with me, please? Claudia, are you here? Claudia? Okay. Do you mind just sending a message in the chat once you are on it, or if you still need a minute? And then we will start sharing that screen. Let me just find you.
There we go. I couldn't.
There we go.
I know I'm
Welcome, Claudia.
with my mic off, but I couldn't unmute.
And we are very used to you speaking with your mic off, so we thought it was one of those moments.
No, I couldn't unmute.
I'm actually going to stop sharing for a second. The code is in the chat, and then I'll share that link, and we can read through the answers as we move along, Claudia.
Okay. Are you able to share the Menti screen on here?
I'm actually going to do that, yes.
Oh.
Can you see it?
Yes, I can.
Awesome. Actually, there are 4 people online, so I'm hoping that we'll have a few responses. So the first question, Claudia, do you mind just...
Okay, so we have a graph, a bar graph on as an image, and it speaks, the graph explains the high income countries all the way to low income countries, and it explains the amount, the total population in those countries versus the number of vaccines, COVID-19 vaccines that they have purchased. And the question is, South Africa falls under the lower middle income category. To what extent is this graph an accurate depiction of South Africa's vaccine availability? And this is the question that we're asking you to engage with right now, please. I've just moved so I can hear nicely. Luzon, I can't see any of the responses yet.
I don't think there are. There are 8 people online now, so I think it should hopefully be coming through soon.
We'll just give it another minute.
Yeah.
I think if you click on the icons with the number, number at the bottom right hand corner, or if not, you'll have to go to the next page to see the answers. I don't know if you've... no.
It's actually just moving to the next question, Prof. I'm hoping that people are still busy typing their responses.
If you go in and quickly edit the Menti, you are live, so you could just edit it to check. whether it's you've put a image on it and you're hiding the results.
Okay, let's click yes. Oh, there we go.
Yeah, there we are.
Thank you for that, Prof. Claudia, there we have a few results. Claudia, you on mute.
Okay, yeah, you know.
There
So
we
some
go.
of the responses, the question again asks, South Africa falls under the lower middle income category. To what extent is this graph an accurate depiction of South Africa's vaccine availability? Some of the short answers are that it's an accurate depiction. Some says that yes, the vaccine is partly available. I think it does, but we have higher income capacities, especially in private, that should be used. It's poor because of the resources Africa has, and considering the limited uptake of the vaccine. Can you scroll down, Lizanne? Some says it's not accurate and it's not an accurate description. I'm not sure. I am not from South Africa and wouldn't know the South African status. I think that vaccine availability has far surpassed our current population, with our vaccine numbers so low in a lull at most, almost. It's modularly accurate. The ratio of population to vaccine availability is not good, as the population is way higher. I think it's fairly accurate of the situation in South Africa. Other commentaries, this is true, as the country is resource constricted and acquiring vaccines is expensive. So for now, it is the process of securing vaccines, although the process is a bit slow. Some colleagues said that the graph is not accurate, and some said they are not sure. I don't know if more are typing, so do you want to give it another second, Lizanne?
I think we can.
So there's mixed reactions to the bar graph. Again, as we see in the bar graph, the higher income countries, the vaccines that they have purchased far exceeds the number of citizens that they have living in those countries, whereas in the lower income countries, obviously the number of people, the population is much higher than what has been secured. And these are obviously for various reasons. We know that it is at the offset, I think it was, Luzanne, a money game, who could secure vaccines while it was still actually in the lab stage. And so that is why we saw that when we were entering the COVAX program, we waited a bit longer for our vaccines. And some of the colleagues have mentioned that there's a lull in vaccine uptake and what we are calling vaccine hesitancy. It seems like by the time the vaccines arrived, people already made up their minds not to actually engage in this process of getting vaccinated, which I think is mind-boggling to many of us at the moment.
If I may just comment quickly, Claudia, I think, in South Africa kind of had the same situation as most African countries, sort of scrummaging around looking for it, and there's a great deal of inequity in access. I think it might be upping, but and there's a COVAX facility in which all African countries are participating, much like South Africa. So circumstances are not just South African, but African.
This is correct, Prof.
I think, Claudia, in our discussion earlier this week, you actually mentioned something similar, where you said that even though we have this vaccine site at our university, that can't be, it's not an accurate, almost representation of what is happening in the entire South Africa, and never mind the continent. Just because we have quite a few facilities offering it in our communities, it doesn't mean that all the other communities present here have it available. So I think that's an important
I think this is what I mentioned to Luzanne, a colleague of mine who lives on the West Coast. When I asked her recently if she'd had her vaccine, and she said, I'm waiting to get mine. And I asked her why she hadn't done so yet. And she said, just remember, we wait for the vaccine center to open once every second week or so. It's not available like it is in the big cities. And I think we often not aware that, I think just in Cape Town, for those of you who know Cape Town, for example, that we just heard that a site opened in Athlone, and then a site will be opening at Grand West Casino Complex. And we're seeing these sites opening all over our university. And right across from us, we have Cape Peninsula University of Technology, and Stellenbosch University as well has opened a vaccine site. So these vaccine sites are coming closer to where the people are, making it easier for them to get to the places. But it's not the case in the whole of South Africa. In your outlying areas, I think the distance between where you live and where the actual sites are might be far greater, and also the time that they're open, the length of how many days per week, etc., and the amount of doses that they would be receiving is not the same as we're seeing in the bigger metros.
Thank you, Claudia.
Thank you, colleagues, for taking part in the Menti.
I'm going to move to the next slide, if that's okay.
That's me. And the next slide on the Menti meter is asking us, to what extent do you think that technophobia influences the registration for the COVID-19 vaccine? And the image that we have is that of the EVDS system. So if you were to try and register yourself, this is the Department of Health site that you would see, and it would obviously start by asking you your age, and it depends on how the rollout has been happening. So in the first phase, it would have asked you if you're a healthcare worker, then it asked you if you're over 60, and now we're still at the 35s and older. And so is our fear of technology influencing the lack of registrations, for example? And we're asking you to please answer this question on the Menti. Okay, so some of the first few answers are, it says quite a lot, it says, and some said extremely. Some colleagues said they're not sure. I'm from outside South Africa. It depends on the context. Perhaps we want to explain that a little bit more, what we mean by the context. Maybe not a phobia, but lack of access and technology and data. Some say somewhat, depending on community or computer literacy. The question was, in what context, African or South African? In some cases, they don't use similar system to South Africa, okay, which is obviously the system that we are referring to specifically right now is the one that is used in South Africa. So especially when we started out, besides the first phase, which is under the Sisonke trial, which was for the healthcare workers, the next phase was for the those people over 60, and perhaps maybe they were the first that experienced a bit of this technophobia. And so another answer says a major component of vaccine hesitancy has come from misinformation, fear mongering. Right at the beginning of the vaccine drive, the first issue was fear around fear around sharing of info and data, which caused major hesitancy. The next person says, very much, it hinders data collection for real-time surveillance of registration progress. Yes, a lot in many African countries. False information plays a major role. It does influence because of literacy levels, not a phobia, but a lack of technological skills. There are a lot of factors which influence. Example, there's a difference in response time when registered on the website versus when they register via SMS. No place to troubleshoot really. And the context, meaning like age, literacy, trust in government, access to IT, that I think the colleague was referring to what I meant when what I asked about the context. And then technophobia has reduced acceptance by many. It assumed to be a deliberate attempt to capture people for suspicious reason. And it says, I don't think this was a problem. The South African government has made many arrangements for those who struggle with technology. Number one, WhatsApp, email, website. Number two, sites with volunteers that assisted. 3, clinical site registration, clicks, Discom, etc., which is your more pharmacy type retail stores. And then another issue is lack of access to connectivity, devices, technological skills, and literacy. Then I said, to a greater extent, many areas do not have the literacy levels on how to use ICT resources. Okay.
I would actually like to see this, the comments be unpacked in the chat as we move along through the rest of the presentations. I think it's really important to have it from different views. I think being in this age, especially in academia, I think we are forced to using technology in a way where even though it might have been a fear at the start of the pandemic, we've been forced to overcome it. And I think in many situations, people were not caught in the same in the same situation as us. And I think this is a discussion that we need to be open to why people might not be signing up for the vaccine, and not to try and alter anyone's belief systems or anything, but just to understand, to have that better understanding of what is happening.
Yeah, and I think, Luzon, so many people actually these days seem to have more access to your smartphone, access to things like WhatsApp, etc. And in the beginning, it was asked of those who are tech savvy to please assist those who aren't, to help them with the registration, especially when we were looking at the elderly, or those 60 and over, and if those were your parents or your aunts or uncles, it was asked of all of us to please help them with registration. But some of the comments has mentioned that actually now you can actually walk up to a vaccine site and you don't need to, you just need your ID and they will assist you. And yet we're still seeing this kind of low numbers in certain areas. And this hesitancy brought on by the fear mongering, as mentioned in some of the comments, the spread of these messages, I think is so captivating that you feel like you must send it on to another 12 people who then sends it on to another 12. So yeah, that is a problem. And I think there's some mixed messaging coming from the health fraternity, as we've seen recently. And that kind of thing also does not help us in getting the program to move along swiftly. Yeah, thank you.
Thank you so much, Claudia. We will definitely share those results with the participants. I think it's really nice to see the active discussion happening there, and I hope that this discussion could be taken a bit further. We can do that in the chat, but for now, I think we need to move along. So let me just attempt this once again. Okay. So our next principle of primary healthcare is community involvement, and you may have heard that through the last two presentations, the word community has come up quite a bit, the broader population. But in terms of primary healthcare principles, community involvement has been defined as the encouragement of patients to participate in health decision making and identifying health needs in their community. It also ensures the respect for diversity, as it allows for the planning and evaluation of appropriate health services for the community. And so next up, we have none other than Dr. Serena Isaacs, who is no stranger to encouraging community involvement. Her background in psychology has exposed her to many facets relating to community involvement and resilience, which includes a current postdoctoral studies that looks at piloting and evaluating family resistance strengthening, a family resistance strengthening program within a rural community on the west coast of South Africa. So I hand over to Dr. Isaacs. Thank you for joining us.
Thanks, Luzon and colleagues. Thank you, everybody, for joining. Sorry, I've got screen here, so I'm all over the place. Luzon, is it okay if I share my screen?
You can go ahead, yes, Serena.
Okay, now I just want to make sure that I'm sharing this on the right platform.
You can see it, Serena.
Okay, is that good? Is it showing in a good presentation mode? It's not like a...
Looks good.
Okay, awesome. Okay, thank you. Colleagues, again, yeah, thanks so much for having me. My name is Serena. I'm from the Department of Psychology. I've been there for quite a bit now. In fact, I actually just got an email a couple of weeks ago about my 10-year service, outstanding service award. So yeah, this is where I'm from. And my goal today is just to tell you, in terms of community involvement, what have we been doing in psychology, and what have we been doing within the 3 specific modules. So within Psych, we have 3 modules which deal specifically, in fact, the modules named community psychology, and we have it at an honors level, and with the 2 master's programs within the department as well. So we've got 2 master's programs. The one is the M Clinical, which leads to registration as a clinical psychologist. And we also have the Research Psych program, which leads to registration as a research psychologist. And that's where I fall in. I'm a a research psychologist. So I just want to give you a bit of background, a bit of history on how this, community involvement even started. Because the department has, we've got this ethos of community work that leads to, that is specifically focused on being really socially responsible and socially responsive to what is happening. So here's what happened. A few years ago, specifically in 2007, I was not working there at that time. I was a student at that time, but within 2007, the previous director of international relations, Leolyn Jackson, approached a few staff members within the Psych department, and that started because they realized quite a few people, specifically on the West Coast, within what we call the Cedarburg municipality. This consists of communities like Citrusdal, Clan William, Gravatte, Elands Bay, and Lamberts Bay. That's what I'm going to be speaking specifically to now. Basically, they then realized that many people were not accessing or using UWC as sort of their first choice university. And then a group of students, about 6 honors students, went up to the region along the West Coast in 2007 to do career assessments, do workshops, which included topics like goal setting, future planning, and really all to encourage students to, apply to UWC, come to UWC. We want to make our university more accessible, more reachable, especially for people in what's considered more rural areas. And then, as a result of that, in 2008, they actually had 50 students from the Cedarburg municipality or from the Cedarburg region who then enrolled, registered at UWC, and it was paid for by the Cedarburg municipality and businesses within the area. And really over the next few years, that involvement within those different communities just evolved. And that's really my, I think the theme or the message of my presentation is sort of the evolution of community involvement and how that has expanded. So over the next few years, the community involvement varied in terms of which specific communities we would go to and the type of work that we would do, whether it would be workshops, different presentations, awareness campaigns, research-related activities, etc. I took over the community psych module and the research program in about 2013, I think, and then the honors community psychology model from about 2014 and 2015. And it has evolved in such a way that we are primarily work within the community of Lamberts Bay. So you could consider it a service learning site where we within our different modules, specifically the master's research module and the honors module, where either towards 3/4 of the way towards the end of the module, we would then take students for about 3 to 4 days to this community to actually start implementing some of the discussions, the workshops, and just some of the methods and intervention strategies that they've learned in class to the community. So a little bit about the community. It's a rural coastal fishing community. Specifically, Lamberts Bay has got about 6,200 people. That was at last survey count, so that is, would have changed by now. The predominant language is Afrikaans, and so we try to encourage students as far as possible. They usually do a mixture of English and Afrikaans when they do engage and do community work. But a lot of low employment opportunities, unfortunately, high alcohol and substance use rates, as well as high school dropout rates, because within the community at the time, there's no high school, no secondary school, only 2 primary schools. And so when learners want to go to a secondary school, they then have to leave the town and go about, is it 30 minutes? I can't even remember the distance, where they have to go to high school outside of town, and then, getting to and from home to their high school becomes a bit of an issue. The ethos of the modules because I teach mostly on these modules, the whole approach, it's a combination of theoretical, because we do have to give some, community psychology theory, knowledge, the resources that are out in terms of articles. So we would do a lot of the theoretical things in class in the form of presentations, workshops, the practical components. But what is very important for me is the experiential component, how students experience the modules and that evolution of thinking from the start of the class to the end of the class. And what I really try to do is challenge the thinking in terms of what is understood by community, what is understood by changing the world, what is understood by ownership and about responsibility, and what we can use, what we know and what we do for the benefit of society in the small ways that we can. So what I mean by that is, so my first class is usually dedicated to what we now call the 6 conversations, because I had the privilege of co-teaching with my previous work, Cassandra, still a mentor. He's now at Stellenbosch University, but he used to start the classes with the 6, what he calls the 6 conversations. And the 6 conversations is really about how do we change the world with one room and one conversation at a time. And so we have conversations about ownership, about responsibility, about accountability. And that's really to challenge the thinking of students and what it even means for them within their capacity. What can they do in the smallest of ways and in the biggest of ways to actually give the gifts that they have to better society, but also to take a mirror, right? So a lot of the conversation is also about, it's really not only about servicing the community, but also servicing the students, because the students themselves are a little community. And how do I effect change in their thinking? What does it mean to be a student who's had the opportunity to study further? And what is that responsibility and how do they move it forward? So that's really what I mean by trying to make it a very experiential module and experiential component for these students. And it's constantly, continuously challenged me as well as how do I, as the lecturer and as the academic, contribute to change in my own modules for my own students and, towards the betterment of whichever communities I'm working in. So what do I do? The way I try to incorporate community involvement in the different modules has to, when I usually have the master's group first, my master's research group. What we go through is what it means to use research psych and use the skills that they've learned within the module for community engagement. What does that engagement look like? What does it mean? Because it's not always giving a workshop, it's not always therapy, it's not always that physical interaction. It's how do we use the research skills in order to support their current functioning? So in whichever way they need that support, how do we support them in their supportive role? So we work primarily with an NGO, so that's what I mean in their supportive role, with an NGO within the community. So 1 year, for example, the master's research students completed a series of needs assessment. They used things like the street intercept method. What they did was literally sort of intercept people within the street and ask them different questions. Just tried to discover if community members were even aware of the social services that the community offered. And the idea was to develop recommendations for the NGO in order to improve services. And you can see in the one part of the screen, that's just an example of what the one type of research that they did was to evaluate some of the programs that the NGO offered, and that was specifically for the children, and to find out if they were happy with the services that people were currently offered, what they thought could improve it, etc. The students also do workshops with learners from the primary school. Topics varied, again, in terms of what the NGO felt was specifically needed for adolescents, children within the community, and with people from different sects. So, for example, they did focus groups with ECD teachers, so early childhood development teachers. And the reason they did that was because the NGO who worked closely with the creche at the time was talking about how do we improve morale amongst the educators, and how do we improve their services, and said, well, the one way to do that is to ask them. And this is what we do. A big part of the engagement is to write up a report in terms of not only what they did, so the methods, the analyses, the results, but very importantly, the recommendations. What could be implemented going further? Based on the results, what can we do? And the whole idea for me is about sustainability, and it's about continuation. It's not just about coming in, doing a workshop, going out. It's also about trying to extend that. That report also sort of serves, I don't want to say serves, but that report is also given to the honors students as well. So with over a period of the 6 months, that's not really 6 months, it's probably about 4 months in total, students have to complete the theoretical components of community psych in class, and in the practical component, after having read through the report, they have to reflect on the report and then decide, okay, if they were to do workshops based on what was found in the street intercept method, what type of themes can be focused on in different workshops? What kind of themes can be focused on in different discussions, in presentations? What we have students do, students have to plan the entire trip. They have to liaise, they have to sort of organize themselves. They have to elect a liaison. They have to liaise with the NGO. They have to develop, we have the food committee, for example, who has to develop the schedule, the meals, check dietary requirements of all the students, who's going to cook, who's going to clean, like everything has to sort of be, written out. I need to see that schedule. So the modules have really evolved over time. And I like to continue that evolution thing. I really want students to take responsibility and to take accountability and ownership and take that initiative when we do this kind of work. So what's very important to me is the liaising with community stakeholders, that they're very specific goals of the workshop. And at whatever workshop or presentation or whatever intervention that is done, that we leave something, even if it's a report, if it's analysis of a lot of data or gathering data that the NGO also needs. And I'll give you an example of over the last few years, some of the funding that the NGO has been able to obtain based on the data and based on the work that has been done. Because so often we do a lot of work and we just do, things quickly, but we don't actually think about what do we leave with them that, communities and NGOs and, other service providers can use to engage their government bodies in order to obtain more funding. Right, so then the post-engagement report is very important. And then lastly, student reflections is something I add to the modules as well. Very important, whether you're in the master's class, the honors class, you need to do a reflective report. We have actually moved that reflective report, and it takes the format of a digital photo story, and the photo story technology is available freely. Basically, what students have to do is document from the beginning of the course up until the end of the course. What have been their thoughts, their experiences, and how has this course specifically changed the idea of community engagement, and what lessons they're taking with them going forward. What's very important is what is the aim of the community, of your involvement. These are some of the lessons that I sort of take. What is the aim of your involvement? What do you want to leave with them, and how does it serve the community, but also as a very good learning tool? Over time, this engagement has evolved really into not only learning and teaching, not only community engagement, but into research as well. We have, like I said, in terms of the learning and teaching for the honors, the master's students as well, but also for research in terms of PhDs and my postdoc as well. Lambert's Bay is actually the site of my research, and I still work very closely with the NGO, whether it's part of module work or not. That is my relationship with them that I need to keep going, and the quality of that relationship is so important for me. Just the other day, especially with COVID, we're not going there anymore. And so we've had to be really clever about how we continue the relationship and continue to be of service to one another. But that's still obviously safe and responsible. And so next week, because part of my postdoc work is to actually implement the program that I developed with my PhD, but we're going to have to do that online. We've also had to be really clever based on resources. Not everybody actually has internet connection. And so there's been quite a bit of the use of technology. So it was quite appropriate, Takwing's presentation, but how do we involve the community? How do we become involved with the community using the technology? So really, like Luzanne said earlier, community involvement has been identified as the encouragement of patients to participate in health making decisions, identifying health needs, etc. What's really become more important for me is how the community involvement and community engagement has evolved over time and how those relationships have evolved. Because like I said earlier, for me, it's really just about the continuation of that. And as academics or people within academia, we have a very big responsibility to do this. And yeah, so these are, I also just have some examples of some outputs. I don't know about my time, but just some examples of outputs that we've been able to achieve because of this relationship with the community. We've had master's theses that students have completed because of the community, some PhDs, myself and some colleagues as well. Lots of training opportunities, training given, training taken, webinar, conference presentations, a lot of research articles as well, mostly from my PhD specifically. This one that's highlighted here, however, I'm pointing at something like I have a pointer. This one that's highlighted here specifically, an article that we did in 2016, which was based on the honor students' reflections of the community engagement. And we did a poster presentation at a community psych conference in Durban because of this paper, but the level of reflection that students have given because of this is just, it's because of such a module, because the module is presented in this way, it's yeah, quite powerful, quite transformative, which I'm really happy about, because ultimately, what else are we doing? Yeah, then just lastly, some of the benefits to the NGO, just really increasing their capacity, increasing their support functions. And, what I see as my role is just continuing not just that relationship, but trying to ensure that they are able to increase in their capacity and increase in their ability to continue to provide effective services for their community and for the surrounding areas as well. Yeah, that's me. So thank you. Thanks very much. Thanks, Luzanne.
There we go. Thank you so much for that, Dr. Isaacs. I think we really appreciated that. I see you have a few comments in the chat. Please feel free to just respond to everyone there. I'm just going to share my screen again. Okay, so the next principle of primary healthcare that we will be looking at is a multisectoral approach. And a multisectoral approach has been defined as providers from different disciplines who collaborate to meet the health needs of patients. It is thus a principle that links both economic and social policies. And so our next speaker is Ms. Violet Adams, and her biography, as you can see on the screen, is testament to why we consider her a front runner in embedding and actively implementing this principle of multisectoral approach in her approach to teaching. And aside from a colorful bio, it needs to be mentioned that Violet played an active role in IPE and its development in the Theewaterskloof region. And so I hand over to Violet Adams. Thank you very much for joining us.
Thank you, Lizanne. Lizanne, will you be managing the presentation?
I'll do that, Violet.
Thank you. Good afternoon, colleagues. I trust you're doing well. What wonderful presentations from our other presenters as well. And I could see the links, and we didn't even speak to each other, the links in terms of our individual roles in the academic setting as well. And I just want to say thank you to Lizanne for the opportunity. And just to say to Lizanne, yes, when she had asked me, that was the first thing that came into my head around the relationship that I have with IPE, and how that has evolved from, in 2010, I was one of the facilitators, and in 2012, I was part of the pilot project that was started up 2012, 2013 in Garabou and in Genadendal. And I see that in the room, Dr. Phyllis and Professor Wahi is here, and it's thanks to their confidence in the capacity of us working interprofessionally also that afforded me those opportunities as well. Lizanne, can we go to the next slide, please? So I'm going to take us to a practitioner's role as to how the multisectoral approach is applied and how we make use of it. And I am, my colleague is also present here today, Dr. Davids, and she is my internal moderator for this module that I present as part of the undergraduate program and curriculum for the social work degree. And it's called the Fieldwork Practice Education module, and it is really centered around preparing the practitioner for the field. With the outcomes of this module, our students have to accrue an amount of 478 hours at an organization where it is they will work multisectorally and intersectorally with other professionals as part of the development and also the qualification in terms of the exit year level, because this is presented at a fourth year level. And some of the outcomes that we have is we skill them with knowledge and theory around how to assess and intervene and also evaluate how their practice will be aligned in 3 intervention levels, which is the micro and meso and macro levels, where it is we engage with our individual, which is our client, and then we move to group settings and also to more the larger society where it is community work. Students will also engage in policy because policy provides guidance in terms of their roles and practice. And this also helps them because they need to align themselves with reflective practice and reflexivity from the lens of using social justice and the ethics of care. Next slide, please, Lizanne. So I want us to think about collaborative work. Are you in your own individual space open to collaborative work, or are you more inclined to work in a more a setting where it is we're working in our silos? And with this as a question, because I'll have a question at the end of the presentation for you as well, we will begin now. Lizanne, next slide, please. With the multisectoral approach, the social work students' role as part of the health team. For many of us, when we think of the social worker's role, wouldn't you first of all think of people thinking of that very lovely definition of social workers are just there to remove people's children? Well, our role is much more descriptive and intensive than just the removal of children. It involves that we are working with aspects of social justice and the collective responsibility as part of a health team as well. We have an advocacy role where it is we advance the human rights of the individual and also the community. With regards to social policy and social entrepreneurship, this is also part and parcel where it is our students will work within an organization and understand how social policy influences how they have located themselves with a particular field of practice. Social entrepreneurship, when students are part of projects, they have to work towards also fixing a budget for a project. So they need to also make an application for donations, whether it is monetary or material support in terms of their community projects. Next slide, please. So when Lazan asked me to present on this, I thought multisectoral has such a broad context. And then I thought, let's look at the principles of this approach. It is about promoting cultural values and fostering collaboration. And when our students are working in the field and even through their courses, because on the 4th year level, the relationship with IPE is also where it is they are attending interprofessional World Cafe workshops, where it is through the faculty, our students are exposed to other disciplines in terms of dealing with a case study or other activities within the World Cafe, where it is they foster collaboration to look at how would they come together to provide services. And in doing so, it ties into how do we communicate across disciplines? Because when we're communicating across disciplines, we have to be so mindful of the fact that we may speak in our own jargon that is rich in our own discipline, that when we're communicating clearly with our partners as part of the service delivery, we need to know that when it is we are communicating, they understand our roles. And it's important for our students to understand their scope of practice when it is they are communicating with their partners, who are the other practitioners as part of delivering a service within the healthcare system. And this ties into where it is sometimes our students find it difficult to understand their role in relation to other roles. And this is why it is the team setting and what we do in theory to teach them to bring towards our practice is to understand, do you know your scope of practice? What are your responsibilities? Because when we're working with, say, for instance, like Dr. Serena, I was listening to her around how working in community, would we know the difference between what a social worker's scope of practice is and that of the psychologist, so that we do not duplicate the running and the delivery of services and ultimately impact on how effective the delivery of services can be within the healthcare system. So earlier on, someone was also mentioning around how do we teach, how do we mobilize resources, living in a country where we are severely under-resourced and challenged in that regard, and not just merely with the resources to meet the outcomes of the health services, but under-resourced like we have currently with the pandemic, where it is our healthcare practitioners are so stretched in their capacity and well-being that we also need to know when our healthcare system is stretched in such a manner, how could we build collaborative interactions where it is we are actually just standing in the gap and helping to minimize the way that these resources have been strained. And this is very important for us to know, especially as we continue to foster partnerships with other sectors within the health sector. With the monitoring and assessing of the performance, this is one thing where I think we could all do more in terms of not working so much in our own silos, but also work towards, if we're doing evaluations of our projects, teach our students to do M&Es, which is part of the monitoring and evaluation for sustainability in their projects. Are we only doing that in view of what we're doing in our scope of practice, but we are still part of the bigger puzzle in terms of the delivering of services? And this is extremely important for us to know that we will be most effective in yielding the best health outcome for the client at the end of the day. Lazan, can we move to the next slide, please? So, in conclusion, for me, in terms of what we have to offer as practitioners with a social work lens, the multisectoral approach, it has many limitations and challenges. And for us to be effective in our roles and our scope of practice, I have a question for our colleagues here today. How can we address the tensions of conflict within this approach across the disciplines so that we be more effective with how we are able to address social issues, address the need of the client, to prepare interventions, even to look at how we can be more collaborative with less stress in terms of with us knowing that we're facing these challenges of not being under-resourced. Can anyone maybe share with us some ideas in terms of how we address some of the tensions of the conflict in this approach?
If you need to unmute, you just lift your hand, use the reactions and raise your hand. I'll unmute you.
I see Takwing says in the chat, it needs to be addressed at undergraduate level. Do we agree with that? Anyone? Lizanne, do you have thoughts on this?
I think coming from IPU, I think we'll always have comments on this, working with the different sectors and working with different disciplines, and coming from a background in physiotherapy, and I think Takwing can testify to this because we've actually, the two of us have embarked on a research study, if I can call it that, with biokinetics because of this, the conflict between the two disciplines. I really just think it's to have that clear understanding of roles. I think that discussion needs to happen actively. We have a few activities that we do within IPU to try and bridge that the conflict, because a lot of the times the conflict arises because of that overlapping scopes of practice, and we find that people don't understand your role, and that then makes that there's conflict. That makes that you butt heads with your fellow health professionals or people from other sectors because they don't understand your role. So we are trying these different activities at health professions education level. Hopefully we can expand it to other sectors as well.
Lizanne, just in, I can nod my head countless times in everything that you are saying. Just in what we've experienced with our students tend to, even with the World Cafe setup, our students tend to go into those spaces feeling a lack of competency, a lack of self-esteem within that, and that affects your delivery of your practice because it influences how confident you can be when it is you are actually dealing with a case of a client, and it impacts on your relationship with another discipline. And I know with that, I know that from an internalized opinion that we still need to do a lot in preparing the practitioner for the field to also rise up against the lack of confidence that they have, because we know that what we do as an institution in terms of our educational role is to solidify their knowledge theoretically, but it's also for them to live that out as a practitioner. I see a few comments in the chat as well. Dr. Serena and says that I think it becomes important to note the context and available resources. For example, in one organization, there was enough resources for a social worker position and not a counselor or a psychologist who then have to take the role of counselor with the huge, already huge workload. Dr. Serena, I agree with that. I agree with you in that. And then it stretches the resources that we have just in human capacity as well. Jana says, I'd like to believe that when we focus on the holistic picture of the patient care using something like the ICF, it forces us as disciplines to recognize that there are so many issues we cannot address, especially not alone, and we need to reach out to collaborate, help with for the sake of our patients. Absolutely, because we are all trained on our theories that we should be person-centered, patient-centered, and that focus should be key, because ultimately we are there for the client, we are there for the patient. And Kuamba, if I'm saying that correctly, says, I agree. Work on shared goals and respect of team members' opinions. Oh, I can also take a leap of how respect can influence, or the lack of respect can influence, how that collaborative action and relationship can be influenced either through power or the tensions of conflict, for whatever reasons they may be. So for us just to be mindful of that going forward. And I just want to say, even for me as a practitioner, I did a workshop. I was listening to Dr. Serena's presentation, and I was reminded of a workshop that I did intersectorally for the Department of Education, for the educators and management structures within the various schools because of the pandemic. And this was just to create a safe space for them. And ultimately that collaborative action came because of an NGO who tended for the project to be able to be of service to right now, where we see the role of educators being completely stretched, and also their well-being and mental well-being for that matter, that influences us. I see Dr. Phyllis also made a comment there saying that interprofessional education needs to happen before we can expect collaborative education to increase health outcomes and for the patients, families, and communities. Dr. Phyllis, the other level, to take that to another level, this is for the practitioner. But if we're looking at it from a divisions and hierarchical structure within government departments, IPE would also so much be necessary for them to know that you're not working just in labor, you're not working in community and safety, but we're all working to the greater good of our society. And sometimes I think we forget that, and we lose sight of that, because it's outputs, it's profit margins, it's all of those things at the end of the day. So thank you for that comment. I think, Luzanne, my time is nearly done. I just want to respond to Labeeqah's comment. Absolutely, students need to learn together and be granted platforms to engage collaboratively so that they may develop the necessary attributes needed for collaboration. 100% Labeeqah, you said it very, very nicely there. And then from Mali, we've got Sannugo that says, just give a comment that we are working in collaboration in Mali with traditional medicine practitioners, and that's really amazing, because that is another sector within the facet of the healthcare system where it is traditional healers and sangomas. In the South African context is also part of the stakeholders for the delivery of services. That's about it for me. I think I've got just a food for thought slide there, Luzanne. So my food for thought is actually coming from Charles Darwin, that says, those who have learned to work, to collaborate and improvise most effectively have prevailed. Colleagues, I want to say, continue to work with being initiative, with innovative ways, improvise in your learning strategies as you collaborate and continue to prevail. Thank you, Luzanne.
Thank you so much, Violet. I see Prof. Shabir Musa has his hand up. Prof.
Yes, I thought I'd just mention, sometimes one needs to think of the of transdisciplinary care as disciplines, particularly within the health service. And there needs to be thinking about how do you collaborate or have sort of stakeholder engagement that is beyond the health sector. And there are other government sectors. And often the idea of multisectoral collaboration is that in primary health care, we need to think consciously about other sectors that are important to the health outcomes. And they tend to be social determinants of health. So housing, electricity, water, agriculture. And I think these are quite important, groups to think about when you're thinking of a community and its healthcare more comprehensively. And it's a useful thought to keep in mind.
Thank you so much for that, Prof. Labeeqah, you are in a bit of a hurry, but I'm going to introduce you quickly. Labeeqah will be covering the final principle of primary healthcare, which is health promotion. And I think I just need to mention that when our health, sorry, I think my dogs are allergic to me. When the health and social science students enters the community and health sciences faculty at UWC, they all embark on one interprofessional module called primary healthcare. And as they move along, they move through this interprofessional curriculum. And so the second interaction that they have with this module is called health promotion. But if we look at the definition of this principle, health promotion has been defined as health education offered to the population with the goal of reducing the need for curative and rehabilitative care. There's a strong focus on prevention when considering health promotion. And so we thought it perfect to ask Labeeqah to speak to this, because for the last 5 years, Labeeqah has been under the guidance of a true IPE and health promotion stalwart, Dr. Wahi, or Prof. Wahi, sorry. She's actively involved in the IPE curriculum and at UWC, and coordinates the health promotion module for second year level, as I've mentioned previously. So I hand over to Labeeqah. Thank you so much.
Good afternoon, everyone. Good afternoon, colleagues. I know that we are a little bit, we are very close to running out of time. So I will try my best to just work with that. So thank you so much, Lizanne, for the introduction. And I think it's important to just position health promotion not only as a principle of primary healthcare, but also as, I think, something that we then build on in our interprofessional curriculum as being the pivotal next step after our students are introduced to primary healthcare at the first year level. So this is the WHO definition of health promotion, and it is quite laden with many terms. But essentially, I think the first line is always, I think, for me, the most impactful kind line or statement, which says that health promotion is the process of enabling people to increase control over and to improve their health. And so just that focus on enabling people, so to basically establish their own agency and control over their own health, with a major focus then on prevention and promotion as opposed to your more curative and rehabilitative components. So when do we introduce this concept or component to our students? So just as Luzanne has mentioned, that at the first year level, our health science students, as well as students from the pharmacy, School of Pharmacy and Faculty of Dentistry, they participate in a theory module that is titled Primary Healthcare. And it's really the introduction of our interprofessional curriculum, where students are provided with that platform of learning, just creating opportunities for them to work together. So the classes are divided into very diverse settings where classes are made up of the various health disciplines. And oftentimes it's the first time the students meet. It's the first time they engage with a student that is not in their discipline. And so that would be at the first year level. At the second year level, we then progress to the service learning module, which is interdisciplinary health promotion. And I think our goal primarily with primary healthcare and interdisciplinary health promotion, as I said, is just providing students with that opportunity to learn together so that they will somehow, engage with these attributes that emerge, which will, we hope and that we do a great job, which will allow them to effectively collaborate once they are qualified. So at the second year level within this health promotion module, the compulsory disciplines who do the module at present are social work, occupational therapy, physiotherapy, dietetics and nutrition, as well as our oral health and dentistry students. And then the third, fourth, and fifth year is where we implement our interprofessional education and collaborative practice program, which constitutes a number of activities, which once again continues on that trajectory of interprofessional education, providing students with a platform where they are able to engage. The reality is that our health disciplines are still, kind of taught in these silos, and our goal is just how can we make our students talk, how can we allow communication and collaboration, whether it be a discussion or a case study, what can we do to create those opportunities? So that's what our third, fourth, and fifth year looks like. And so fundamental to our module, of health promotion in teaching it to our students, we, just as this session today is focused on the principles of primary healthcare, the 5 action areas of health promotion is actually drawn from those primary healthcare principles. And so it's the 5 action areas come from the Ottawa Charter for Health Promotion, which was established in 1986, and it remains one of the most influential policy documents in health promotion. And it really established that guiding kind of principles around the values that need to be fundamental to any practice of health promotion. And those include building healthy public policy, creating supportive environments, strengthening community action, developing personal skills, and reorienting health services. So essentially together, these 5 action areas really make up the goal of health promotion. And that is to have an impact on the socioeconomic and environmental determinants of health, and not just at an individual level, to focus on population health as opposed to individual, and to emphasize prevention rather than treatment, than curative kind of aspects. And then, of course, to build capacity in communities and individuals. So there is obviously a great overlap with our previous speakers. So that is really the fundamentals of health promotion and how we teach it. The second very pivotal thing to the module is the settings approach, which is something that we really try and get our students to understand, that it's not just something we grab out of the air, but rather that the settings approach is it's the understanding that it's within settings, so whether school, work, our communities, the area in which we live, where we work, it's in those settings, in those contexts, that health needs to be made more conducive, or positive health behaviors. It's those settings that are most influential in our lives, and it's those settings where you can really use it as a vehicle to practice health promotion. And so, yeah, there are a number of settings, characteristics of the settings approach. I won't go into that just due to time, but essentially, yes, based on these fundamentals of health promotion and health promotion theory, it is therefore our aim that students will gain from this the essence of what health promotion is. And of course, often when we teach, we tie it back to, or we draw it back to our first year primary healthcare module. We'll often refer back to, for example, the principles, the strategies. We want students to understand the link from primary healthcare to health promotion, of course, which forms that foundation of interprofessional education. So just how we practically ensure that this happens at the secondary level is through collaboration. So as I said, students are placed in interprofessional teams right from the outset. So they're not placed in classes that are only of their discipline. A class is made up of, let's say, 40 students, and those 40 are maybe 7 physio, 7 OT students, 10 social work, etc. So, you know, your class for the semester is actually a diverse one. So that's the first way in which we ensure that we can, you know, kind of implement these principles or get students to engage with it practically. The second one is to develop a health promotion project suitable for implementation in a school setting. So the school setting is following on from the settings approach, which is the one that we choose to focus on for our students, where prior to COVID-19, our students would actually go out into the communities that surround the University of the Western Cape, the low-resourced communities, and they would actually have to develop a health promotion project and then implement it at selected primary schools for a period of 6 weeks. And it's such a, you know, that's the service learning component, and such a wonderful opportunity for students to engage practically with not only developing a project, but then actually seeing the implementation thereof. And then lastly, students are required to reflect on the service learning experience or a significant experience, since we are not able to go into the schools at the moment. But I think these are the 3 really pivotal parts of what our module or health promotion at the University of the Western Cape focuses on. And then this is just an example of some of the health promotion projects that the students have developed over the last few years, where we were still able to go to the primary schools. And as you can see, just based on what they have presented, the final product is really what can be deemed a research poster or a scientific poster. And so students, it's not just that they understand health promotion as, okay, let's do some fun activities with the learners, you know. It's not that. They actually have to think about it as they would if they were ever to, you know, once they are qualified and join an NGO or join an organization or be a postgrad student. It's something that they would have to understand methodically. So looking at it from a needs analysis or situation analysis right at the beginning, they would have to establish aims and objectives, etc. So this is just some examples of what our students have come up with. And I think that they've really done some great work in terms of how they, you know, understand the needs of the particular school, and then transform it into a project that can kind of address those needs, and also in their interprofessional teams to draw on each other's skills when they come up with the action plan over the 6 sessions. So that's another one of the projects here. So the students do really good work. And I think it's been the hardest part about COVID in terms of this module, is that the 6 weeks at the school, you know, and it's a lot of what Serena, Dr. Isaacs did mention, was the fact that, you know, it's about actively engaging with that community and going into the community. And it's often the first time our students have even driven. I mean, it's kilometers away from, it's not even, I would say, 2 kilometers from our university, but it's the first time our students have ever stepped outside of that. And I think it's just, there's an unpeeling, you know, that happens when students do take that step, and you can truly see how students are built for community work, and how it falls into place that I'm not just a health professional that's going to engage in a clinical setting, but this is also such a big component of what I will do one day. So yeah, that's a really great, it really comes full circle when you see that and you witness that. So just my final thoughts. With the goal of reducing demands for curative and rehabilitative care, health promotion works to build an understanding of the determinants of health in individuals, families, and communities. Individuals, families, and communities thereby develop skills to improve and maintain their health and well-being without requiring curative or rehabilitative care, but rather by being more preventative and about really embodying that kind of promotive life where you live with health behaviors always in mind. And I think COVID has really been that time where we haven't had a choice but to do that. So in this module, the desire to empower through health promotion extends into provoking community action via the school setting. thank you so much for listening. I know that it is over time, but I've tried my best just to make that as concise as possible.
Thank you so much, Labeeqah. Okay, there's a bit of an echo. I think I really appreciated that, and I know how much you had to cut on your presentation, so thank you for being aware of the time. So because we are so aware of the time and our time constraints, our final activity, I don't think it would be fair to ask people to stay on and engage in this activity. But I do think, Dr. Labeeqah, I do think that we can, just for food for thought, and I would like my colleagues, Labeeqah, Prof. Wahi, Prof. Musa, to come in here, and if there's anything that you would like to add. But I think that when we look at the health promotion at primary healthcare and the principles that I spoke to in the beginning, when we move further than a first year level, so when we teach students, our health and social science students at the first year level, as they move further, we as the Interprofessional Education Unit, we might not have that constant interaction with them, but without even realizing, and I think it's so it might be unintentional from the different departments, but the principles are embedded in their curriculum without them even noticing it. And I think it was just an important space for us to share how we do that. And I think that as we move along, as active health professionals or academics that fall within the health professions education sphere, we need to start thinking broader than our current scopes of practice. We need to start considering the types of activities that we do to ensure that the impact of COVID-19 doesn't affect us even more than it has been affecting us. And so for food for thought, I would like us to leave here and consider all the presentations we had today and maybe engage with it. Contact the speakers if possible. I'm sorry for throwing it out there, but contact the speakers if possible. If you feel the need to collaborate with someone and you feel that your department, whether it's in the clinical field or in your health professions field, that they could benefit your department in a certain way, then please do make contact with them and please do speak to them. Is there anything from my colleagues? Prof. Musa, Dr. Champion, Claudia?
I think it's great stuff. Well done. I think it's been very useful sharing all these kind of experiences from UWC. I think others in South Africa and Africa, I think this being an African meeting, I think will find value in what you've done. I think it's a pity, like we say, we couldn't ever chat and share more. I think lots of people have experiences. I just want to mention one which was put out there about the, by Rokia, about traditional healers, and I think that they are part of the team, and it needs us as health professionals to acknowledge them and look at ways in which in the African primary healthcare team we find ways to engage with them, even if the system doesn't allow them to be formally part of the team. We need to see them as part of the team. So thank you all once again, very well done, and I'm sure that everybody found value. Just to mention that the presentations and the recording will be available on the web page. So for all those who've missed little bits and gems all over, thank you.
Thank you, Prof. Prof. Wahi, would you like to add anything before we conclude? Dr. Phyllis? Claudia, anything you would like to add? If not, thank you so much for your time. Oh, Claudia, would you like to add?
I was just trying to see if maybe Dr. Phyllis or Dr. Wahi was busy unmuting. So no, just thank you so much from the IPEU to all our colleagues across the African continent for joining us today. Thank you, Prof. Musa. Thank you to Lizanne and all the speakers today. It was very interesting.
Let me allow people to unmute themselves because I kind of blocked it to keep the noise down, but they could if they want to. I think Gerard wants to say something and maybe Prof. Wahi.
Thanks, Prof. Musa. Yes, good afternoon to everyone, and thank you for the insightful presentations. I think the presentations are so unique because we are re-engineering primary healthcare. We're talking about NHI, and I think IPE features in most of the health policy documents and the call for collaborative practice. So I think the presentations are quite aligned to that. And I think that I hope that this creates sort of more awareness for the need for collaborative practice. And especially on the brink of us being in a pandemic, there's so much opportunity for us to collaborate and to work more closely together. So I think thank you to all the speakers for a very stimulating presentation and discussion. Well done.
Are there any other comments from our panelists? Violet, Dr. Isaacs, Takwing, anyone that would like to add anything? Not sure if Cassandra is still on the call. Oh, Cassandra is still on the call.
Not necessarily from me, Lizanne. I just want to say thank you for the opportunity to speak to everybody and for everybody's engagement and comments. I really enjoyed it. Thank you.
Thank you, Serena.
Lizanne, from me, I would just like to say that I hope that the IPEU unit on campus continues to break barriers and challenge the glass ceilings in terms of what we can do, not just locally or nationally, but also regionally.
Thank you for that, Violet. Claudia, would you like to wrap up? I'm not sure if anyone else has something to add. I doubt it.
Thank you once again, everybody, for your time. I know we've gone a little bit over time, and it's because our speakers had so many interesting views to share, and we wanted to give them that opportunity. And I think when Violet Adonis from Social Work was busy speaking, and she gave us an opportunity to engage with each other, we didn't want to stop the flow of that conversation because it was going so well. And we thank each and every one of you for your very valuable time this afternoon. And thank you to everyone who put together the presentations and came and taught us a little bit something new. We always have something to learn, and like Dr. Musa, Prof. Musa said, hopefully there's something in it for each and every one of us. So thank you very, very much from the IPEU at UWC, and for everybody at AfroPHC for joining us this afternoon.
Thank you, colleagues. I think I should add thank you to our interpreter, Alexandra. Thank you. So I was wondering, there's someone speaking there. She's trying to say something, but thank you so much for that. Keep well, colleagues, and stay safe. And I hope to engage with you all soon.